Hello and welcome to Cutting Edge Pain Relief. Today, I am honored to have a guest who is phenomenal, Dr. Amaretti, who's here to talk about the utilization of a procedure and technique called the herniatome using CT guidance. And that treatment option, he's going to explain in depth and detail the value that it has in order to be able to help patients that have a number of different complaints in the spine, the minimally invasiveness, the safety, and the efficacy that's associated with it. For those of you who are joining us, please welcome him. He's actually currently in the south of France, near the French Riviera, which I'm sure is much more beautiful than our Indiana site right now, even though we have great weather. But he's easily 6 to 8 hours ahead of us in time, has taken the time to join us. Dr. Amaretti, thank you so much for being here with us.
Hello, thank you. You're welcome. Nice to see you.
Yes, so thank you so much. And I think you're going to talk to us a little bit about this procedure. What were the origins of how it came about? And maybe you can give our watchers and viewers some understanding with how did this come about and how is it utilized?
Yeah, in Europe, we use all the percutaneous intervention under CT guidance, vertebroplasty, kyphoplasty, spine, screw fixation, and also steroid injection. We believe and we know that the target is easier to decompress, I mean the herniated disc, if you are under CT guidance to be exactly on the right place. When you put your probe on the disc, the best way to decompress it is to be exactly where the pressure is. And the only way to do that, to have a precise target, the CT guidance for the moment is the best way.
Okay, and so for some of our patients without the medical background, just to kind of give insight, that CT guidance is a 3D picture so that we can see multiple different areas as we access that area, and it really lets you be able to see the entirety of the body. In addition to the components of the spine, you can see other portions like vessels and nerves and such, which is something that Europe's been doing for quite some time and has really kind of advanced this element of the procedure. So with this, can you give us some insight about the difference between what intradiscal pressure causes in terms of pain and how that intradiscal pressure is what might be some of the things that we're trying to target and improve?
Yes, when you have your herniated disc, I mean in lateral position, for example, the nerve will be pitched exactly in the foraminal place, and you need to be exactly on that lateral approach. And if you have a posteromedial herniated disc, you can enter directly on the canal because the probe is very thin and decompress on the posteromedial axis. I can show you some slides, for example. So the patient is under local anesthesia on the CT scan, and you see here a herniated disc with the pain on the leg, right? Because it's a L4 location, L4, L5. And with the CT scan, you exactly write the target and the way you enter on the herniated disc to leave the pressure, to diminish the pressure exactly where the nerve is compressed. How can you do that? So first you do practice local anesthesia, and you insert the needle inside your herniated disc. And you create a provocative discography to be sure that it's the right level. And with the pressure, you reproduce exactly the pain of the patient. So you communicate with the patient, asking if the pain is the same. And when the prerogative discography is positive, you insert the probe you see as a guide wire, like a Seldinger technique. That means that you're exactly where your first needle was, and it's very easy to insert the curved probe to slip on the guide wire and enter in the disc. So with a straight needle, you can enter a curved probe. And with that curved probe, you can extract, you can decompress widely the herniated disc. I mean, the field of decompression is much bigger than the straight probe, and you create a kind of olive of decompression. You see, sometimes you can extract a big part of the herniated disc to decompress, and the patient in real time feel the decompression. The patient will tell you exactly, well, I feel better on the real time when you decompress step by step the the disc. So very interesting to communicate in real time with the patient, and you feel the decompression when you are exactly where the herniated, where the nerve is compressed.
Okay, so that is a phenomenal overview with being able to explain, what the patient feels almost instantaneously many times, and being able to communicate with the patient is different than what we frequently get with someone who has that general anesthesia, has the grogginess afterwards, has that huge incision, and is trying to be able to overcome that incisional pain. But because it's a minimally invasive approach, it allows for you to really be able to kind of hone in how well did we target this. Is that pretty much correct?
Yes, exactly. For us, it's very important to have a patient in outcome patients because they come in the morning and in the afternoon they come back home. And our local anesthesia, that's very important as well because they, well, it's not a procubitus anesthesia. Sometimes they get some complications, and patients come back to work and to living normally daily immediately 2 days after the procedure. And we think that with the local anesthesia, it's easier to come back to classical, to a daily live.
Okay. So just to break it down for some of our patients, what we're talking about is an incredibly innovative treatment for really being able to deal with disc pathology using CT guidance in combination with some degree of fluoro that allows for us to be able to get after that disc. So you made a reference earlier that talked about paramedian versus the aspect of lateral recess and possibly even foraminal when we're talking about that orientation, correct? So
Yeah.
maybe you can talk to our patients and our viewers rather a little bit about, so you could have a disc bulge in multiple different locations, but we can see it via CT. So it really allows for you to be able to have kind of a three-dimensional aspect of what's in front, what's behind, as well as the structures for safety. But let you kind of clarify that even a little bit more.
Yes, for example, do you see my screen now? Yes. So for example, with the city guidance, you have a 3D location of the whole anatomical structure, the nerve, the dramator, the vessels, and it's very easy.
Dr. Amoretti, you might have to
Yes.
expand that slide so we could be able to see it even maybe a little bit more.
Yes. Do you see my slide now? No? Tell me. Is it okay now?
Perfect.
Do you see?
Yes, perfect. Looks good.
Yes. So you see in that example, you see perfectly the nerve root, the dura mater, and the fat you have between the two structure. You see perfectly the herniated disc, and you have a space between the two structure. You can only have this precision with the CT guidance. You agree that with fluoroscopy, you can't know where you are if you do a medial approach. You can't know if you're here or in the other side, of you're exactly between the nerve and the herniated disc. With the CT guidance, you have a perfect 3D location of the probe, and you enter between, for example, that true structure. Imagine that, for example, the herniated disc is on that part, on the foraminal root. You can easily go directly on the foraminal, and when the probe is curved, you can decompress from the medial part to the foraminal part. So you create a real decompression uh, as the volume is big as an olive. And you know, thanks to the CT guidance, exactly where you are and where you decompress. You do that uh, in comparison of percutaneous discectomy in open scar or in on endoscopy. With the CT guidance, you do have maybe the best, a better field of view, but also the probe is only 2 millimeters. So you can do the same work with a better field of view with only 2 millimeters of incision. That's why you can do that. You can perform it under local anesthesia.
Okay. So the other thing that I think you alluded to is the degree of post-op is really minimal to none. So there's traditionally not an overnight stay, which is something that I think is phenomenal. Maybe you can kind of comment on that in terms of that in relationship to recovery time.
Sorry, I did not understand your question.
No problem. So again, because of the minimally invasiveness of this, the degree of recovery is much shorter, just in
Yes,
general.
yes,
But
yes. Sorry.
also, the time that the patient would stay is this is not something that most people would have a hospital stay for. Can you talk a little bit about that?
Yes. So there are no scar, no muscles lesion, and the patient, for the sport patient, for example, can come back to sport immediately. Because there are no scare and no problem of any muscles. Also, it's outcome hospitalization. So if they don't want to stay at the hospital, there are no problem. They can come back immediately. There are no hemorrhage or something else, no infection as well, because the entry is very small, and they can immediately come back to for the sport people, professional sport people. We do have a lot of known and other well-known sport people coming there to decompress a herniated disc and come back to their sport immediately. Thanks to the local anesthesia, no scar, and no lesion of the muscles.
Okay. So to that point, are there certain patients that are really good fit for this? And if so, what's their normal presentation? How do they normally have various different clinical signs where some of our viewers watching would say, hey, that sounds like me, and they may be a candidate.
Yeah, exactly. Well, it's patients who have lumbar pain with radicular pain, I mean sciatica or neuralgia, resisting to all medical therapies. We have a lot of history of opioid treatment, of very strong antalgic medicine, painkillers, and in which the MRI show uh, a conflict between the herniated disc and the, the nerve with a good hydration of the disc, mean that when you will leave the pressure, well, you have the pressure in the disc, so you can diminish the pressure. Mean that the patient who have a very thin disc are contraindicated for that procedure. So it can be young patient or older patient with a space between the two end plates. So usually patients are coming before surgery. People who don't want surgery immediately come in my university after steroid infiltration, after ozone therapy, after physiotherapy. So people resisting all that treatment who want to come back without pain, with a fast rehabilitation, come to be decompressed under CT guidance. And after few days, the VIS, I mean the pain, dramatically decrease.
Okay, so to paraphrase, because that was a lot, it's someone who has pain, particularly radicular symptomatology, pain that shoots down the leg, that's that classic sciatica symptoms that's in place, and they probably have gone through some conservative treatments first. So they may have done some physical therapy. They may have had steroid injections. I noticed that you made the mention of ozone, which is where you guys are more advanced in some aspects of Europe, but many practices are starting to introduce that as well to be able to get some degree of benefit, and it probably hasn't been so sustainable or lasting. And then this treatment could very much be a good presentation and a good fit because it doesn't matter about the age demographic. And as we talked about from the local anesthetic component, it takes a much broader range of individuals who probably aren't excluded because their cardiac or pulmonary issues that you might have for anesthesia are minimized because you can do this with a range of different anesthesia types that don't necessarily preclude or prevent someone from being able to have a procedure that can give them relief that can be longer lasting. So to that end, I would think that also not having to make a major incision in the multifidus and particularly changing the structural pieces might be something for us to talk about. But what I want to know is who are candidates not for this, but we're going to take a short break and we'll come back and have that discussion in just 1 second.
Okay.
Again, welcome for you joining us. We have the distinct pleasure of speaking to Dr. Amoretti, who helped develop and found Herniatome, which is a unique product that uses CT guidance to be able to target disc bulges in a minimally invasive way that decreases hospital stay, potentially allows for you to have less risk for infection, and also allows for you to be able to have a much shorter recovery time. And what we're talking about is indications and contraindications. He just spoke about someone who has pain that goes down the leg and not having any limitations based on age, and it being very useful for those individuals that might have cardiac or pulmonary effects because it really doesn't stress that like what you might have with traditional general surgery. And again, if I might say, it's our pleasure to have him because he's joining us 6 hours later in the south of France and is jumping on our live stream. Again, Dr. Amoretti, it's a pleasure to have you with us.
Thank you so much.
So who might be people that this may not necessarily be the most optimal treatment for?
Yes, in our experience, the inclusion criteria is, as we said, lumboradiculalgia between L1 to S1, pain lasting for at least 1 month, meaning that people are resisting all conventional treatment. What's very important also, it's MRI showing evidence of radicular conflict and a clinical radiological accordance, and the VAS, I mean, a pain, important needing important pain killers. So usually the patient we have is patient coming after 1 month, and we want to recover fastly and with a real herniated disc that we can see on the MRI with a good correlation, and in which the approach, thanks to the CT guidance, can be optimal. The contraindication, well, sorry for that, patients who have degenerative disc, I mean Pfeiffer, Tiedemann 4 or 5, with an important impingement, and patients who have an extruded herniated disc. Sequestration of the herniated disc are not a good indication, because you don't have the right target with the CT scan, and also the pressure you will leave on the disc will not depend on the pressure on the from the sequestration disc, right?
Exactly. So to kind of paraphrase that, so patients, if we're using this as this model to kind of represent this a little bit, if you have an increased degenerative disc where the narrowing is present there, it could be a bit of a challenge, I would imagine, with being able to try to get the probe there. But in particular, if you have a herniation that's significant in nature, that by going in and being able to decrease the pressure, it doesn't resolve it as much as what we would hope or like. So that type of option might be a bit of a challenge to being able to use something like this. However, the utility of this is huge compared for the number of disc bulges that exist. And I don't want to kind of speak out of turn, but the way I would see this is that many times when we're talking about disc bulges, sometimes we're looking at discectomies here in the States, but sometimes we're looking at much more aggressive invasive procedures. So to be able to do a minimally invasive procedure that has, obviously been preceded by conservative therapy with little trauma to the patient, I think allows for not only better recovery, but also better long-term options. Out of curiosity, can you talk about how this might compare to something else that may not be quite as muscle sparing? So if you do a traditional approach, obviously that's a cult into the multifidus a bit, and there's some differing thoughts about that. Can you give us some commentary about that, Dr. Amoretti?
Yes, usually when you do open surgery, the recovery is very long. When you touch the posterior muscles and the scar you create, the patients need few months to recover. That's why we think that thanks to the CT guidance and thanks to the percutaneous decompression, you have the best of the two worlds. And patients who have contraindication of surgery, and also sport people who don't want to go to surgery and prefer to have just a decompression of the herniated disc, come to our university to be decompressed without any lesion of the muscles.
Okay, so we have a question coming in, And I believe that question references this a little bit to discogram, which maybe you can be able to show a video to kind of give us some clarity about it. But she poses, is it similar to a discogram with another step to extract the disc material causing pain? And I think there's some nuanced differences, but perhaps you can explain that a little bit better.
Yes, exactly. Well, the discogram is the first step to see exactly where the herniated disc is, to see the contrast media on the herniated disc, and you will have an anatomical uh, view of your herniated disc, and you can after insert your probe. So it's a step 2 on the herniated disc after the discogram, and you create a cavity thanks to the motor rotation, and you do an aspiration on your herniated disc. So first you do the discogram, and after you decompress the herniated disc. So it's in 2 steps. It's a discography and after a decompression.
Dr. Amoretti, might you have a video to be able to show us as well?
Yes, we do have some videos. You will see in real time what's happened. So I share my screen and I'll show you immediately. So for example, one patient who have a conflicting L5-S1 resisting all therapy. So we perform a CT scan to see the approach you will see, and you see under local anesthesia with a dual guidance, with fluoroscopy and CT guidance, we perform a surgical disinfection in outcome patients. I go faster, and you see, for example, I'll show you how there is an aspiration of the liquid, and you can imagine that the nucleus pulposus is the same. You see, you don't need to be inside, there is an aspiration immediately. So you perform it under local anesthesia. This is a posteromedial approach. And so you perform a little incision, a provocative discography to be sure that we're on the right, that it's the right diagnosis and on the right level. You insert the needle, and step by step, under fluoroscopy and CT, you enter on the herniated disc, right? So you are in a very precise position. Gently, you come in your disc, looking at the nerve, and you confirm the right position with the CT. You see here, for example, it's a posterolateral approach. So we know that we're on the right place. We perform a discography. We know that we are exactly where the pressure is the higher. And we insert a probe in which the extremity, the distal extremity of the probe is curved. Why it's curved? Because you can widely create a cavity on the herniated disc. So when we say decompression, it's a real decompression. You feel the pressure decreased in real time. And after you rotate the probe, at 360 degrees, gently, and you slip all around inside the herniated disc. So it's intra-hernia approach, in that we do exactly the same as classical surgery. I mean, you decompress, you don't inject things, no alcohol, you don't burn the disc, you do all these kind of things. You only decompress and extract the, the disc, like we are doing in classical surgery. At the end, we inject steroid injection. We practice steroid injection. Why? Because sometimes the pain increase secondary to the inflammation you can have after the procedure. And with the steroid injection, you don't have the rebound effect. So another case in which we perform a lateral approach, you see, totally lateral, and under CT guidance, it's a L4, L5. We enter in the disc in a very foraminal way. So you see that the only way to be on the right place is with the CT guidance. Believe me, it's very tricky on the under fluoroscopy. It works well because you decompress the disc, but with the CT guidance, you decompress the herniated disc. So you see how it works. So you decompress in real time. So you see it's not very painful, sometimes it is, but you see you can enter easily now in the disc decompressed. So you create a cavity on the disc, on the lateral disc, and not in the whole disc. So we believe that the evolution of this kind of probe is not to extract the disc, but only to decompress and to let the materials inside. So the result, there is a multicentric controlled trial done in Europe, in Switzerland, Italy, France, with 5 centers, showing that the evolution of the pain in the patient was the same in all centers. There is another center in Spain as well. And the VAS decreased dramatically immediately after
Dr. Amaretti, on that slide, do you mind expanding it a little bit so we can see your results, so we can see the differences that are in place? No problem.
Yes. So I'll show you again how we do that. So you see the needle, you break the proximal port, you slip the curved probe inside the herniated disc. That's very interesting. We perform a discography, right? A discogram. You see here the contrast media on the herniated disc. That's very interesting. You insert your probe and you aspirate, and what you are seeing here is a cavity. You see, that's hair inside the herniated disc. Here is the contrast media before and after. You aspirate, and the herniated disc is here on the probe. What was here with the conflict you have on the nerve now is outside with, you see, a very small incision. So that's the material we extract. And what I told you before, we believe that it's better to let the material broad inside the disc, and maybe it will be the next evolution of this modern approach.
So if I can interrupt for one quick second. So we definitely want to have an understanding about where you think further advancements are coming. So we want to circle back to that. But just so people understand, For us, we were really privileged to have you, but you're the first author on these multi-center trials that you made reference of. And although you were really very humble with how you presented it, you're the man, with putting all this together and making this really be able to assess how we're able to bring benefit to patients. So just so those of us who are watching, we have an understanding of like what's really being presented is first class data from a cutting edge treatment option that Dr. Amoretti has developed and really been able to put forth. How can we bring forth a product that really allows for a uniqueness that's in place? I interrupted you, and I think I didn't want you to stop sharing your slides. I think you're going to show us a little bit about the pain relief and how much benefit there is that's associated with it. I know that we've had a few questions, actually quite a few questions pop up in the interim period that I have kind of neglected mentioning and discussing about their questions. So maybe we can answer a couple questions and go forward from there, some of which I think you covered. But one of the questions was, if we don't have access to CT, can this procedure be performed under fluoroscopic guidance alone? And I don't want to kind of steal the words out of your mouth, but as I understand it, I think you were pretty explicit with saying, if you did it with fluoro, you can decompress the disc. But when you do it with CT, you can really be able to decompress the hernia that exists, which is really the component that's causing the compression. But I'll let you kind of put that in your own words. It's a sure procedure that you found it originally, and maybe you can kind of clarify that further.
Yeah, you can perform it under fluoroscopy. You'll do a nucleotomy. You have to guess under fluoroscopy where is your herniated disc. So maybe if you compare the approach with your diagnosis CT or MRI, you can try to guess where your herniated disc is. Some approach, for example, foraminal, when you know on fluoroscopy, you can guess that you are on the foramina, you can perform it, but sometimes you can't be sure that you are exactly where the herniated disc. Sometimes your herniated disc is more lateral, sometimes it's just behind the joint, sometimes it's more medial, and it's more medial. You can have a very lateral approach to be sure that you're on the posterior part and the medial part, and with your probe, your curved probe, you can decompress the posterior part of your disc. So yes, you can perform it under fluoroscopy. A lot of centers do it under fluoroscopy. Probably the fact that the probe is curved make the decompression easier and probably more effective. But in my opinion, for when you have a daily activity with a CT guidance, when in L5-S1, for example, it can be very tricky because the access with the lateral part is difficult. You can do it with the CT guidance with a medial approach to be between the dura mater and the nerve, or sometimes you can do a direct approach, but you can't be sure under fluoroscopy that you are on the right place. You can do it, it's validate, but you will have sometimes some difficulties to decompress the disc exactly where the pressure is, right?
Right. So just to be clear for people to kind of have a representation. So if you take a look at this spine model and you're talking about L5-S1, this model doesn't really reflect it all that well, but the ilium sometimes can get in your way as you're trying to get to the disc. So there are different options that you have with CT that allow for you to be able to access this, whether it's a direct approach, as was mentioned, or even if you come off to the side and you know what you're encountering when you're getting in that space. So that way you can really be able to have even a more robust, and to kind of use a traditional surgical phrase, a more elegant approach that allows for you to be able to get there with less damage, and you also know exactly what you're targeting so that you have a response. So one of the things that you alluded to is next steps in evolution. Can you talk to us a little bit about where do you see this progressing to, and what might be some of the new future approaches of how this might even be optimized even further?
Yes, what we think is that it's better to let the nucleus decompress inside the disc, and you change all the biomechanic characteristic of the herniated disc when you broil it, when you destroy it, and when you let the disc inside the disc, when you let the nucleus inside the disc. Because we think that when you extract a lot of material, you will diminish, you will decrease the height of
Disc
your
height.
disc. That's the
Mhm.
first thing. Only to decompress. And the second thing, probably in the future, we believe in injection of, we don't know, PRP or stem cell, where we have created a cavity to uh, you see, I think that both things are the future. You decompress and you inject stem cell or PRP. I think that will be the Ferrari or the Rolls Royce of the percutaneous of the discectomy. We believe in that, and our laboratory are working on that.
Yeah, I think that's incredibly interesting. We believe in it too, because we do actually PRP and stem cells aggressively at our clinic. And so, I mean, to that, we've seen a number of studies that haven't been focused on being able to decompress, but they have seen restoration of disc height with certain types of injectates of orthobiologics. So to me, I feel like, as you mentioned, this is the best of both worlds, or as you stated, the Rolls Royce, because you can do the decompression, and you can also be able to deal with things that are not the biomechanical or the physical component, but they're actually kind of the, if you would, milieu of what's going on intradiscally that may be causing some of the problems and some of the issues, and be preventative in nature. So that's just phenomenal. Let me pose this to you, particularly for our viewers. Let's say that you had to encapsulate this on a billboard, if you would. How would you define this context of this procedure so someone can be able to understand it?
Yeah, that's an excellent question. Real life question. When you have a bending disc, sometimes it's very difficult to focus where the pressure is. So we believe in the clinic. Mean if you have radicular pain, lateral right pain or left uh, sciatica, we go where we believe that the disc is a more give more pressure. So sometimes you don't see exactly where your herniated disc is, so you decompress only where the nerve root is, and with results are good if you correlate the clinic with the decompression you have, and you can perform it under fluoroscopy in that case.
Okay. Again, thank you so much. I know the hour goes late. It's probably close to 11 p.m. in France where you're at. So we won't go too much longer. Maybe two more questions, if you would. The question I'd ask is the following is, so are there other things that maybe I missed earlier that you'd like to clarify further? Any other points that you really feel like are some things that are germane for us answering and informing our viewers?
Yeah, well, it's in our point of view, patients should know that there is a step before classical surgery. And for the whole patient, I mean, all patient in which general anesthesia is contraindicated, but also patients who are working and sport people we need to recover fastly. And with the new percutaneous decompression, you do the same thing as surgery with the mini invasiveness of steroid injection. So people might understand that the evolution, thanks to the evolution of radiology, of CT guidance treatment, help them to recover fastly. And in the future, probably it will be much better in terms of decompression, but also in terms of injection of new kind of regenerative therapy.
Okay. Well, when I was trying to end this, I had someone jump in and said, I have a question too. So one of the things that they posed is, can two levels be done at the same time?
Yes, why not? Sometimes it can happen. You perform provocative discography. If both are positive, you can do it on the same time. Sometimes it happens. Yes, you can do that with the same probe.
Okay. So to that end, I guess one thing that I like, because this will be up on our site and our YouTube channel for evergreen content, but still we have individuals who are going to want to know more about this. Where can people find more about what you do as well as the product itself so they can get more information and really be able to use that as a resource?
Oh, I don't know in US where are the centers who are doing this kind of procedure. I know that in New York and some other states they are performing that. Concerning the material, there are different laboratory who are selling the herniatom, so you can, I believe, you can see that on the internet and or ask to your center how to.
So
Yes,
what I would
exactly what.
say is, so this is herniatome, as I recall, right? So this is where someone would
Yeah,
be able to find that product and be able to look into it. And I think that the various different individuals here in the States may be able to direct to physicians that are local and close so that they can give some insight about how to be able to learn more about the procedure, as well as how to be able to find a physician that can hopefully be able to help them as well. So this, I think, kind of clarifies and has a number of different things that are in place here in the States that might be useful for people.
yes, I think that in the future, a lot of centers will perform this in Europe. The major part of university hospital in France, for example, perform this kind of treatment before surgery with excellent results. So we believe that the cost effectiveness of this procedure will expand in the whole world.
Okay. Again, Dr. Amoretti, thank you so much for joining us at this late hour where
Thank
you're
you.
located and giving us really the firsthand experience of the developer of this procedure. We really do appreciate it. And if you're open to it, we'd love to have you back, particularly as we talk about progression of how this works with orthobiologics like PRP and stem cell in Europe. And we
Yeah.
can see really what have been some of the developments and what is the true cutting edge technology that's in place.
Yes, with pleasure.
Okay. Thank you so much. Have a great day, everyone, and take care.
Thank you.